To invite Dr. Namrata Sharma, who will be talking about types of riboflavin that we use in various methods of doing cross-linking. So let's hear from her.
So thank you, Dr. Rajesh, for making me a part of this very interesting instruction course on keratoconus. I would be talking to you about types of riboflavin and the current status of accelerated cross-linking. I'm sure this has already been dwelled upon that the cross-linking does strengthen the cornea because of the way it works, and it also increases the biomechanical resistance of the cornea. Riboflavin is a photoactivated chromophore with absorption peak at 370 nanometers, large hydrophilic molecule, inadequate to penetrate an intact corneal epithelium, and that is why you require corneal deepithelialization. And it is a non-toxic agent, and it is also a photosensitizer. I think this mechanism has already been discussed on how it works. Now, as far as US FDA approved solutions are concerned, there were two of them which were initially approved. One was riboflavin in 20% Dextran solution, and the other one was riboflavin phosphate solution for corneas which are less than 400 microns. And if you look at the available riboflavin solutions in the market, these are the following. So riboflavin with Dextran is 0.1% riboflavin with Dextran. Then you have a hypoosmolar riboflavin which doesn't have Dextran. Then you have riboflavin for transepithelial collagen cross-linking, and then you have riboflavin with HPMC, and then you have even higher concentration of riboflavin for extra procedures, which increases to 0.22 to 0.25%. So essentially these are two types, Dextran based and HPMC based, and what we need to know is that osmotic effect of Dextran reduces the corneal thickness. And the HPMC based, there will not be any corneal thinning present. It increases the diffusion rate, and there is also reduced loading time. Now this was a study which looked at Dextran versus HPMC based solution, and the difference between the two was that the 20% Dextran caused more thinning as compared to the HPMC, and so the treatment also was at a greater depth when the cornea became thinner with 20% Dextran, and so as a result the demarcation line also shifted more posteriorly as compared to the one where HPMC was used. At our center we are using this with no these are the two types of riboflavin we use with no financial interest or proprietary interest in any one of them. Isoosmolar riboflavin, which is 0.1% riboflavin with 20% Dextran, is the one which we have, and for hypoosmolar riboflavin, this is constituted in physiological salt saline salt solution, and this is meant for thinner corneas. Now, transepithelial riboflavin will not penetrate an intact epithelium, so several agents have been used like BAC, EDTA, vitamin E, TPGS, and some people also used iontophoresis for the same. Even oral riboflavin has been tried by people, but there are increasing side effects of systemic side effects such as risk of sunburn and photoaging of the skin. Now, I'm sure Dresden protocol has already been discussed, the classical Dresden protocol. The accelerated protocol, there are various ways by which this can be done by using various energies for a varying time period. And the essential part is that the energy remains 5.4 joules per centimeter square. So you can either use 9 milliwatt for 10 minutes, or you can use 18 milliwatts for 5 minutes. And this is as per the Bunsen-Roscoe law of reciprocity. Now, there is a need for rapid protocols because the standard protocol is time consuming. It is more comfortable if you do it rapidly. And excessive dehydration and corneal thinning, which follows following 30 minutes of UVA treatment, is more as compared to when you don't use as compared to when you don't use these standard protocols. Ex vivo experiments have shown that whether you do conventional cross-linking or accelerated cross-linking, the biomechanical properties are going to be similar. The advantage is that there's reduced exposure time, improved patient comfort, and lesser risk of infection. Now, this was a study which looked at standard versus accelerated cross-linking, a retrospective study, and like I discussed earlier, the treatment demarcation line was more with the standard protocol as compared to accelerated one, and demarcation line is more superficial with the accelerated one as compared to the standard one. This is a meta-analysis of 1,158 eyes, and again it concluded that consideration of less corneal thinning favors the accelerated collagen cross-linking, whereas the deeper demarcation line and greater changes in the minimum keratometric values in conventional cross-linking may indicate a higher treatment efficacy. And although there is a difference in the way they work, but as far as the strengthening of the corneal tissues there is concerned, both of them are equivalent. Now, this was again a 5-year result of epi-off versus standard versus accelerated collagen cross-linking, which did not show any difference in terms of mean depth of corneal strobal demarcation line between the two procedures, and even the Kmax and the UCVA and the BCVA were comparable. In pediatric cases also, it has been shown that accelerated collagen cross-linking offers stable keratometry and corneal thickness up to 36 months of follow-up. Now, as far as the accelerated collagen cross-linking protocols are concerned, could be pulsed versus continuous, normal fluence versus high fluence, pachymetry-based accelerated collagen cross-linking, photorefractive intrastromal cross-linking, and LASIK extra procedures. So when you do high fluence accelerated collagen cross-linking, there will be minimal changes in the thinnest preoperative areas, and it reduces the thickness variability among the central 6 millimeters. This is as shown here. And this was a study which looked at pulsed versus continuous light accelerated collagen cross-linking, and concluded that pulsed light allows optimized intraoperative oxygen availability, which is a critical issue, and so it improves the postoperative functional outcomes because you're not cross-linking for the entire period, and the oxygen is available in the period when you're not cross-linking. And this also looked at the confocal microscopy study, and this was also confirmed that deeper apoptosis and demarcation line formation occurs with the pulsed cross-linking compared to the conventional cross-linking. Then pachymetry-based accelerated cross-linking, something that we were discussing, is now going to be the future, which is going to determine the cross-linking parameters depending upon the patient's pachymetry. And then of course you have the photorefractive intrastromal cross-linking, which is also done by accelerated protocol, but it is done for myopia. And then you do have LASIK extra, where LASIK and accelerated collagen cross-linking is done simultaneously for better refractive and keratometry stability. Now, these are essentially the summary of the studies of accelerated collagen cross-linking available in literature, and some of them, they say the results are equivalent, and some of them, they say that the results are better with the conventional cross-linking. Now, the concerns for accelerated cross-linking are that the biomechanical effect of the cross-linking is oxygen dependent, and that is something that needs to be looked at, and we really don't know the biomechanically, there are not very many studies which have compared the biomechanics of conventional versus accelerated cross-linking in prospective randomized controlled studies. Now, this is just to show that high fluence accelerated epithelium of cross-linking protocol in this study provided Dresden protocol like corneal strengthening. So they concluded that it really doesn't matter even if you do accelerated collagen cross-linking with the high fluence, the results are similar to conventional cross-linking. There is variability in terms of progression criteria used, grading methods for severity assessment, riboflavin solution used, soaking time used, UV radiation used, and follow-up duration in the literature which is available currently. And I think more robust data and more well-planned studies are still required to actually know whether accelerated collagen cross-linking is equivalent or is non-inferior to true conventional cross-linking. So to conclude, by our experience and by the literature which is available, accelerated collagen cross-linking allows corneal stiffling in cases of progressive keratoconus, and variable results are reported in different studies in terms of functional outcome and corneal strengthening. The accelerated collagen cross-linking with 9 minutes and 18 millivolts in one study does show that it is similar to the standard cross-linking in experimental studies, but we do need to corroborate this further with the long-term studies and more robust trials. So we do recommend that these studies are required, and more so in the multicentric studies should be taken up with the standard parameters in these studies which should be used. And also I think the high-risk group, the young children in the syndromic association, should be evaluated separately from the general population studies. So thank you very much for your kind attention.
Thank you, Dr. NAMRATA, for an excellent presentation and for covering the topic